So for an ASCO 2026, I think one of the bigger takeaways is more information in frontline large cell lymphoma with the presentation of the frontline study, which was evaluating the combination of lenalidomide, tafasitamab, R-CHOP in patients versus R-CHOP, which did show a 6% progression-free survival benefit in a high-risk IPI 3 to 5 patient population. So this is providing more information in the second and positive study we've had in the last 5 years of a novel combination on an R-CHOP backbone in patients with large cell lymphoma. Additionally, we have further follow-up with several bispecifics, specifically the combination of mosunetuzumab and polituzumab in the SUNMO study, as well as the follow-up study with glofitamab and the 179 study in patients with relapsed refractory mantle cell lymphoma. Uh, Additionally, with some more, uh, you know, rare subtypes of lymphoma per se, we have information with updates on a novel treatment with a PRMT5 inhibitor in patients with Hodgkin's lymphoma, as well as some information about some novel concepts with patients with T-cell lymphoma. So if we look at CAR T-cell therapy or the bispecifics or the antibody drug conjugates, I think for the most part, as of today, the curative treatment remains the CAR T-cell therapy. And, if we can, the focus is trying to get patients to CAR T-cell therapy. I mean, I believe the good thing we have about CAR T-cell therapy with the two products we have approved in the second-line setting, we have avenues to take young and frail patients to CAR T-cell therapy. So the CAR-ineligible patient population is very rare. Now, if you have a situation where a patient has overly aggressive disease or for some reason or logistical reasons cannot go to CAR T-cell therapy, based on the data we have now, it appears that at least the bispecifics with chemotherapy or the bispecifics together with antibody drug conjugates do provide suitable options for patients as a bridge to CAR T-cell therapy or potentially as definitive treatment options for this patient population. Now, if we move beyond a situation where, again, we have a situation where a patient may be either concerned about refractoriness to a T-cell directed therapy, meaning progression on CAR T-cell therapy or progression on a bispecific. The antibody drug conjugates that we have available, whether it be loncastuximab tesirine, polituzumab in combination with bendamustine and rituximab, or polituzumab in combination with gemcitabine and oxaliplatin, or the Echelon 3 regimen, which was brentuximab R squared, provide all their options for patients who may have not be suitable again for T-cell directed therapies or progress afterwards. So again, just to summarize, I mean, the preference would be to get most patients to a T-cell directed therapy, and I believe the options we have today provide a wide range of options for all patients, irrespective of age or fitness. But in those situations where these patients either cannot get to these treatments or do not respond to these treatments, the antibody drug conjugates provide another avenue for hopefully getting remissions in patients with large cell lymphoma. So I know in the early stages of the introduction of bispecifics or other immune therapies into the community space, a shared partnership, usually where patients are started on these medications, and after the higher risk period passes, the patients are then transferred back to the community setting. I think that's an early step, but I think overall, I think as we provide more exposure to community physicians with these novel medications, and there are more avenues for patients, for these physicians to either get experience or some sort of knowledge about the efficacy and the safety of these regimens, I think the comfort level will improve where these regimens will be utilized more. So if we look back to sort of the checkpoint inhibitors, originally these medications were highly concentrated in academic centers, but as the comfortability and exposure increased and the sort of approval, especially in multiple solid tumor subtypes, we saw a level of comfort in the community physicians where today they probably utilize these agents and can manage adverse events better than even academic sites. So with the bispecifics, as they continue just to be exposed outside of lymphoma spaces, I do think that we will see increased comfortability and utilization on the bispecifics for the community physicians. And in those cases where there is an uncomfortable or a situation where a patient needs closer monitoring, partnerships with the academic centers to get the patients, especially through step-up dosing, and then transferring the patients back to the community center for the remainder of their treatment will likely be some of the processes we'll see moving forward.